or tonight. It's a terrible evening out there, and I'm sure everybody just wants to curl up and go to bed. It's just that time of year, isn't it? So thank you so much for joining me, and I've got about half an hour. Is that right, Angela? So we'll go as quickly as we can because I do have quite a lot of information here. So I wonder if perhaps if everyone should mute perhaps their screens, and yeah, and then we can do questions through the chat function, or I can you can unmute at the end, and if we've got time for questions there, we could go for it. So and now it's not going to go, so I will just try once again to get it up. Okay, here we are. So hopefully we're all good. Okay, so this evening I just would like to go very quickly over a little bit of background about MECFS and look at a definition and some diagnostic criteria and briefly touch on the impact of MECFS, what it does to our children and adolescents. But I'd like to talk mainly about management because it is the management that is really important when we're dealing with these children. So what do we know about myalgic encephalomyelitis or chronic fatigue syndrome? And the answer is that we don't know much more than we actually know about it. There are so many unknowns still with this terrible illness. But we do know that it's a debilitating long-term illness. It's been classed as a neurological condition by World Health Organization. In spite of that, it is not classed as a disability in New Zealand, and people find it very difficult to get any kind of funding or support for it. It's been known as Tapanui flu, yuppie flu, chronic fatigue syndrome, so a variety of names over the years. And pre-COVID, the estimated prevalence was approximately 4 to 8 people per 1,000. So in Canterbury, that was about 3,000 people, and that included about 10% of those were young people. So it is quite a significant illness for young people. It's across the board in terms of age or gender or ethnicity. However, it is diagnosed 3 times more often in women for some reason. And there are 2 main onset periods. The first that it's mainly diagnosed. People suffer with it across all age ranges, but for some reason there are 2 main times in people's lives when they tend to get diagnosed. And that first one is that adolescent period between 10 and 19, and then the second is that period in the 30s. And so we have a lot of young women of childbearing age who are really debilitated by this illness. The average age of onset is 33, but it's been seen for the first time as old and people as old as in their late 70s and as young as 4. There's no known cause that can be pinpointed to causing it. However, about 3/4 of people can trace back to a viral illness being the trigger of the onset, and glandular fever being a real biggie. People who test positive for Epstein-Barr virus very, very frequently. But the flu, COVID-19, of course, since COVID has been around, we've seen a massive increase in MECFS. But it can also be chronic stress, major life traumas. There's a number of things that seem to be able to trigger it. And there may be a genetic predisposition to it. So, unfortunately, there's no diagnostic laboratory tests available for this illness, and a lot of people, when they have their raft of blood tests in the days before getting diagnosis, most of the blood tests will come back normal. However, there are a number of pathologies that are actually going on that can be demonstrated in the laboratory, but we just don't have the tests available for them. But the first one is that abnormal physiological response to exercise. So people who have this illness can, if you match them with normal controls or healthy controls, and if you put them both through a raft of physical exercise, they would probably do fairly similar on the first day of doing the exercise. The test results would be fairly similar. However, testing them 48 hours later, the normal controls will be able to repeat their exercise results. People with MECFS will be far, far, far below. They just won't be able to come back to repeat the test results that they had first of all. So it's sort of an abnormal anaerobic energy system. There's also impaired energy metabolism at the cellular level. So what's happening with people who have this illness is that their cells just cannot use the nutrients and oxygen that are available to create energy in the way that healthy people will. And there's also measurable abnormalities in a range of body systems as well that show kind of a lot of symptoms. In the past, it's been incorrectly attributed to psychological causes, and there was no any scientific research that pointed to this. It was just a group of psychiatrists who decided that this was probably a psychiatric disease, and in the 80s in particular, a lot of damage was done, and a lot of people were told that this was something that was all in their heads, and unfortunately the ramifications from that are still being felt today. And as there are no diagnostic lab tests, there's also no cure. There's no cure that we know of for MECFS. There are no even approved treatments or medications. The medications that are used in this illness are used off-label. The medications that are used for other things and have been found to have some kind of results for people with MECFS. So therefore, our focus is on management, and it's on managing the symptoms of MECFS. In 2015, for the first time, we got because there's no tests, so therefore we need some quite good diagnostic criteria, and these were put together in 2015. So 3 things must be present for a diagnosis. The first one is a greatly lowered ability to do activities that were usual before they had the illness. This must have lasted for at least 6 months, although in children they shorten it to 3 months. This lowered ability must be present for about 50% of the time, and it's always accompanied by profound fatigue. They must also have post-exertional malaise, and this is becoming unwell and really feeling very, very ill following any kind of exertion. And we'll talk about that shortly. It's the hallmark symptom. If people don't have post-exertional malaise, they do not have MECFS. And third, they must have sleep dysfunction. So this could be a range of things. It could be circadian rhythm disorder, where they go to sleep later and later and later at night and sleep into the day. It could be hypersomnia, where they sleep for hours and hours and hours. It can be restless or broken sleep. Teenagers often report very vivid dreams and trouble getting to sleep. So those are the 3 things that must be present for a diagnosis. And then plus or minus either cognitive impairment, just trouble focusing, concentrating, memory loss, following conversation, decision-making, just a real sort of cloud of cement. Often people have described it in their brains. So either that and or orthostatic intolerance, which is on assuming an upright position, so from going from lying or sitting to standing, that people feel really awful. They get dizzy, thumping hearts. They feel like they're going to be sick. They think they're going to pass out. It's that kind of sort of horrible, dizzy, fainty feeling. So those are the 5 main sort of symptoms of MECFS, but there are also a number of others that are present in some people and not in others. But these are the 5 that are sort of recognised as being the main symptoms of MECFS. So in children and adolescents, the presentation's a little bit different. So children will often present more with like abdominal pain, nausea, appetite issues. Now that's that will seem to be their main issue. Adolescents will often have headaches, a lot of orthostatic intolerance, and abdominal symptoms as well. And it's really important when children start to become unwell that they have a thorough medical assessment to rule out other conditions, because once again this is a diagnosis of exclusion, so people must be thoroughly tested before they have this diagnosis. And properly managed MECFS for children and adolescents, the prognosis tends to be better. So children and adolescents tend to do better. A large proportion will improve. Some will become cured, will go on to lead normal lives. The majority will go on to have some kind of impairment of some sort or another, but a large percentage, about 80% of children and adolescents, if they're well managed and properly managed with their illness at this stage, will go on to have really good improvements. How do they explain it? So children and adolescents, they often really struggle to explain how they're actually feeling so that you understand, what they're feeling like. So they'll say things like, I don't feel right, but I don't know how to explain how I'm feeling. Or they'll say, I'm not tired like being sleepy, I'm tired like being sick. Or I want to do things and my body won't let me. And this is a really strong thing with MECFS. It's not lack of motivation. Children and adolescents want to be able to live a normal life. They want to be doing what everybody else is doing, but they can't. They can't do it. And what they may not say is that they often, as they start to become unwell and they start to experience post-exertional malaise, they'll start to shut down. So they'll become non-responsive or minimally responsive. And so this is a physiological thing that's happening. It's because they're unwell. It's not that they're being defiant or rude. And if children start to act like that, become very quiet, withdrawn, not able to engage, it's a very strong sign that they need to stop and rest immediately. So the main symptoms of MECFS, the 5 that we talked about, what do they look like? So fatigue in MECFS is a persistent lack of physical energy. They feel weak all the time. It's not made better by sleep. And it's not just tiredness, it's an absolute physical heaviness. And it's not just, and it's unrelenting. It's there all the time. They don't get you never get a break from it. The post-exertional malaise is, if you're not sort of used to thinking about it, is a little bit difficult to describe, but it's a worsening of all symptoms. It's delayed and it's prolonged. So it doesn't happen straight away. It often happens a lot later, and it often lasts for days to weeks. And it happens after exertion. And it's not just physical activity. It can be any exertion. And for a lot of people, triggers are things like cognitive, and they've worked really hard and they've been in their head for a long time, or emotional or social stresses can be just as triggering and draining as going out and doing something physical. Overstimulation, sensory stimulation, children, adolescents like this can't face them all. It's too much. It's that sort of thing that will be the triggers for setting off post-exertional malaise. And the post-exertional malaise feels horrible. It feels horrible. It feels like they're getting sick. It's not made better by sleep. And it can actually get worse before it gets better. You often don't see it until 1 to 2 days after the thing that triggered it. And that's what often makes it really hard to work out why you're feeling like that. You went to a party on the weekend and you're fine, and then suddenly on Wednesday you can't get out of bed. So that's that delayed kind of response makes it very difficult to work out sometimes when you've overdone things. And it can last from 24 hours to several days before people return to baseline. And the things that you might see would suddenly need to lie down after doing something that they could normally do. Complaints of feeling fluey, and people often say they think they're getting sick again. I had one young lady recently who kept going to her doctor because every 2 weeks she felt like she was getting the flu, but it wasn't. It was post-exertional malaise. They get things they could do previously they can't do. They can get emotionally dysregulated. Things like my body hurts, I'm too tired, are the sorts of things you might hear. Sleep dysfunction is another symptom of post-exertional malaise, but you feel exhausted. When you wake up in the morning, you feel worse than when you went to bed. It's unrefreshing sleep, and people will say that over and over again, unprompted. I wake up in the morning, I feel unrefreshed, I feel terrible, and it can often take a long time to get started in the morning. Broken sleep, shallow sleep, difficulty getting to sleep, or sleeping for hours and hours and hours, much longer than a normal teenager would sleep. Cognitive impairment, it's that, as I said, just like people have described it, their brain being in cement. And for some people, it's the most distressing symptom because they can't find words, they can't process information, they get overwhelmed, overloaded, they have memory issues. It's a really awful thing to go through. And orthostatic intolerance, which is really actually common in adolescents, and it happens when they change position from from lying or sitting to upright, and can often be really exacerbated when they have been upright for a certain amount of time. It suddenly makes things get a lot worse. So they feel lightheaded, dizzy, they might go really pale, they might get nauseous, they might think they're going to faint, the heart's pounding, all of those sorts of things as the heart tries to push the body around. And standing in line, for example, or in a hot shower or in a heated swimming pool can make these sorts of things a lot worse. And a lot of children will unconsciously do these postural counter maneuvers, which is where they're moving to get their blood flowing around. They're doing it and they don't realize why they're doing it. So, but it's moving the lower body to pump the blood around the body to counteract the effect of the pooling. And some adolescents may not even describe the lightheadedness. So you might have to ask them, how do you feel when you stand up? What's going on? And that's when it'll come out. So why is it so debilitating? And that's the thing about chronic fatigue syndrome. It's not just fatigue. It's this combination of all of these other things. It's the sleep, the ongoing poor sleep, the brain fog, pain, often the post-exertional malaise. They often have gut issues, sensory hypersensitivity, light and sound can be just too overwhelming, and often they have other things going on as well. So it's that combination of things that really make people's lives very, very difficult and very horrible. There's a wide spectrum from mild to very severe MECFS, and about 25% are in the mild section. 25% are in the very severe. Those are the people that are never seen because they can't leave their bed or their home. And then 50% are sort of in the middle and have varying degrees of impairment from it. The management principles. Well, first of all, we don't recommend extreme energy drink, but we do recommend things like making sure that you find healthcare professionals who understand and support the children. The next really important thing to do, principle, is symptom management. Because there's no cure, we have to manage the symptoms and treat the symptoms. And we recommend a stepwise approach to this. So what you do is work out which are the most troublesome symptoms for you, rank them, prioritise them, and then work through them one by one to see what can be changed and what can be lessened over time. Learn and practice pacing. Pacing is the most important skill that anybody with MECFS can ever learn. It's about staying within your energy zone. It's consistency over intensity. Moving from desperation to patience. Now, the progress in this disease is about slow, incremental increase in activity over time. And it's something that is often really, really difficult to manage because it just, it's so difficult to be disciplined and structured and consistent all the time. And new treatments, try them one at a time. Otherwise, how do you know what works? So pacing is getting that good balance between activity and rest. So people who pace well are active when they're able and they rest when they need to. And it's the most important part of having MECFS. And often we explain to people, and especially kids, like this analogy of having an underperforming battery. And what happens when all of us go to bed at night is we plug in our chargers, and most of us, I imagine, wake up in the morning, we're 100% charged. People with MECFS wake up in the morning, they're lucky to be 60% charged, often less than that. And their batteries run out quicker and they're slower to recharge. And, this is the thing that we've got to remember, is that people with MECFS are starting in a different place from us every day. They start on much lower energy levels. And the thing that people have got to learn is to stop before they hit the red, stop before the energy is in the red. So for children, pacing and energy management is learning the concept of energy envelope and baseline. So the energy envelope is the amount of activity that they can safely do. And baseline is the level at where people can function that doesn't send them into post-exertional malaise. They'll still often have symptoms at that level, but it won't send them into post-exertional malaise. It won't send them into a crash. And finding that place can be really tricky because it often fluctuates as well. And then learning the 5 Ps. The 5 Ps are really important. The first one is pacing. So it's having rest before, during, and after activities, and breaking activities into small chunks so that they don't have to do everything all at once. It's do a little bit rest, do a little bit rest, do a little bit rest. It's about good planning, spacing things out, using timers so that if you're really engrossed in something, you stop, and stopping before you get symptoms. It's prioritising. You only have a certain amount of energy, so what are you going to spend it on? Position, reclining, lying down positions are often better in terms of energy conservation. And then prevention, use preemptive rest strategies. So before, if it's a school day, you rest before you go to school and rest after you come home. If you've got an appointment, you rest before you go. It's about recharging that battery so that you've got enough to carry you through the activity that you've got to do. And older children, this is what we do with adults, and older children would often benefit from heart rate monitoring, where they're given a calculation and we calculate a maximum heart rate that they should be achieving. So they should always be operating underneath that heart rate. And if they have devices that can track their heart rates, they can have little alarms on them, so if they exceed the heart rates, they know and they can stop what they're doing and rest. and the heart rate often goes up before they get symptoms. So it can be a really effective tool in helping them manage their activity. Sleep management. So most for children, it's about sleep hygiene. It's just all of those good things that we know to do, avoiding stimulants, having a really good sleeping environment. And it's better to have good sleep routines rather than try and reduce the sleep length, or rather than try and get them to do more in the day so they're tired at night. It's better just to have a very good sleep routine. Exposure to light in the morning can help prime our circadian rhythm so that we have a more natural sleep rhythm, so that we wake in the morning and we're more likely to be sleepy in the evening. There's lots of really, really good sleep apps that are out and about. White noise, there's stories, there's mindfulness, there's relaxation. And in amongst all that, it's important to be aware of normal adolescent sleep patterns, because their sleep demands are still very big. They often sleep long hours, and morning is their bad time. Orthostatic intolerance, to manage that is fluids and electrolytes is the very, very best thing that can be done. They must have at least 2 litres a day for adults, 2 to 3 litres a day for adults and adolescents, and electrolyte sachets, at least one of those a day to increase their blood volume, and add salt to meals. And these sorts of things can be on their own very effective. Really good to wear compression garments, socks or sports skins. And if they know that something's coming up, like they're going to be standing for a while, or going to have a hot shower, or they're going in a heated pool, it's good to just chug a couple of boluses of cold water beforehand, and that will increase the blood volume and help them get through that particular incident. And these postural counter maneuvers that we're talking about, it's all about contracting and relaxing the muscles in the lower half of the body to get the blood moving more efficiently around the body, and to prevent the fainting and the lack of oxygen in the brain and the heart. Cognitive impairment, there's lots of little tips and tricks, mainly pacing, because when, like everything else, cognitive impairment increases when they're in post-exertional malaise. So it's really important they recognise when they're unwell and manage that. Also, just managing things that will get in the way of that'll be distractions. So managing pain well, managing sleep well, any kind of secondary mental health conditions that might be occurring, like anxiety, depression, and managing the orthostatic intolerance as well. So being really good about doing as much as possible in those areas. Lying down can often be better. Good nutrition, fluids and snacks, and then just all these little tips and hacks about timing, performing cognitive things when you're at your best part of the day, utilising apps like timers and recording devices, and avoiding the overstimulation. So being in a quiet place, not doing more than one task at a time, avoiding, glare on screens and things like that. And then other issues, all of these things are very common as well in MECFS, and particularly with children and adolescents have gut issues. So it's really important, even more than normal, for them to eat a healthy diet. Many of them have dairy protein intolerance, so if they probably a good idea to get tested for that. And elimination of certain foods can help as well. That should be done under a dietitian's sort of supervision. Mast cell activation syndrome is something that happens, like it's an abnormal allergic response. That often happens as well. That can be treated with antihistamines. In pain, massive issue, a very big subject to cover, but it's best to try and be as multi-pronged as possible in managing pain, and using all of the techniques and things that are available to do that, including heat and cold, TENS machines, massage, relaxation, all of those sorts of things. And medications are not used very much. They try to avoid using medication in children and adolescents if possible. So while all this is going on with trying to deal with a unknown and potentially chronic illness, adolescents, of course, are going through massive changes and massive work. It's a huge time of turbulence and change and growth, as we all know. And they've got to achieve all of these kind of milestones, dealing with peer pressure, body image, academic pressure, hormonal changes that are leading to emotional volatility. So they're trying to deal with all of these things as well as come to terms with an illness that gets in the way of doing a lot of these things. So just a few things that can help parents, I think in particular, if they can be involved as possible with the management part of their illness and directing it and control, that can be a really good thing for them to do. They're more engaged. It gives them more sort of power, more feelings of control. There's a lot of good digital tools that are out there that teenagers in particular would love to play around with and give them a lot of feedback about what's going on with them. Validation about the emotional and social things that are happening, talking about it, trying to keep the communication lines open, using humour, trying to have as much social connection as possible, involving them with care planning and medical appointments, and that will set them up for independence and self-advocacy as they get older. And in girls as well, it's with menstruation, there's the additional challenge of hormonal cycles and surges, which can really impact their MECFS as well. So keeping that in mind. So inevitably, there are times when children and adolescents will crash, when they'll get the post-exertional malaise, and they won't get past their bed for a long time. It'll be the centre of their world for a while. So how do we manage crashes? First of all, remembering that it's not a behavioural or psychological thing that's occurring. This is actually a physiological response, and the focus has to be on rest, reducing stimulation, and supporting comfort. And so during a crash, there's all of these things you can do to minimise the impact, get rid of stuff they don't need to do, have a very low stimulation environment, be flexible, physical comfort, lovely soft bedding, easy to digest snacks, electrolyte fluids, and normalising the need for full rest. This is something that you've got to do to heal. This is not something that you're choosing to do, but it's something you've got to do to heal. And limiting that screen time. Minimise social demands, and they recommend that the family can create a bit of a buffer zone. They take turns at providing care and can be the intermediary between the child and the rest of the world. And just reassurance to say this is a temporary thing. It's not, it's necessary for your health. It's necessary for you to recover, but you'll get back to what you need to do. And a crash support kit can also be a really helpful thing for children to have, which includes electrolytes, earplugs, eye mask, weighted blanket, some simple comfort items, and any pre-approved sort of medications or supports for symptoms. What can parents say to others? And I know that this can be really challenging, particularly with friends or associates that don't understand the illness and see the child when the child is at their best, but doesn't see what's happened when the child comes home and needs to spend all day in bed. So parents can say things like, my child has a medical condition that causes delayed symptom crashes. We need to pace and limit stimulation. We'd love to participate, but we have to do it in a different way. That's the sorts of things that can be said. And some helpful things that parents can say to the child, it's say things like, I'm sad that you can't go, but how about, I think your body needs to rest today. And normalizing what's going on. Your body's telling you what it needs, and that's good. You need to be able to listen to it. Make sure that the children understand that their illness is not who they are. That's a different thing. Think about other ways to celebrate or participate, acknowledge grief and frustration, and consider that there are age-appropriate support groups or connecting with other affected children. And I know for a while there was a group of adolescents in Christchurch that used to meet in every couple of months, and they'd do an escape room together, and that seemed to work really well. How can people respond when people ask them how they are? There's just a few ways of responding as well. It's not just saying, oh, I'm fine. And within the family as well, there's sort of different communications strategies that you can use. And it can be difficult in a family, particularly when people are not feeling well themselves, or there's often less than sympathetic responses. But, trying to create that judgment-free space for children to actually say how they are, simple check-ins, acknowledging the siblings and what's going on for them. If there's tough times, holding family meetings and talking about how things are going to be different for a while, and using hopeful but realistic language about the future. Always must hold on to that hope and have future planning and looking forward. I guess you would be very aware of the school challenges, much more than I am, I'd say, because you're dealing with these children at school. But these are, some of the things are the unpredictable attendance, because this is such a fluctuating disease, and it makes it really difficult for children to participate consistently. The cognitive dysfunction is such a big thing. Problems with focusing, processing, particularly complex information, synthesizing information, retaining, all of those sorts of things, delayed response time, and, choices can be overwhelming. There's lots of triggers, post-exertion malaise triggers, noise, lighting, social interaction, sitting up too long, and then the orthostatic intolerance stuff, having to sit up at a desk or having to walk any distance can be a challenge. And just that fatigue, inability to sustain energy for a full day. So these are some of the accommodations that have been identified. I'm sure you've got others that you use as well. I don't have to read through them all, but I'm sure there are lots of things that you use in your everyday teaching that would cover a lot of these issues: the attendance, the environment, the cognitive support, physical support, sensory support, activity modification, and communication tools as well. Just very quickly talk about a few things that often come up, and some things that are not recommended that people are having to deal with, particularly from doctors. Graded exercise therapy is not recommended. It has been disproven. It has been used in people with MECFS, and 80% of people got worse with this, so it is not recommended. Cognitive behavioural therapy as a treatment will not work, because MECFS is not a psychological or psychiatric illness, but it often can help people develop strategies for dealing with a chronic illness. And the Lightning process, which is a neuro-linguistic programming program, and costs a lot of money. Very few people do well on it, but for most people, what tends to happen is that they exceed their energy limits and tend to crash and burn. Any treatment that says, I'm going to cure you of your MECFS, be very, very wary of it. And just safe exercise, because for some people with milder MECFS, movement activity is necessary and important. Just a few tips. They must be stable. The person must be stable before they increase activity. So they must not be going crash, burn, crash, burn. They must be quite stable and have developed good energy and activity management strategies. Good to try gentle exercise first, preferably, often seated or reclining is better. If people want to try an increase in activity, probably to start with no more than 2 minutes at a time. And you would try a little bit of increased activity and then not do it again for 2 or 3 days to monitor whether or not you're getting any ill effect from it. So you would do that activity, watch and wait for 2 or 3 days to see if you get any post-exertional malaise. Try it again, watch and wait for 2 or 3 days. If nothing happens, then you're probably safe to move or exercise at that level. So it must be that kind of increase. You must be stable and you must monitor it very, very carefully. Just some general resources, and on our website we have a lot of resources. NZ Care for Me is a Facebook page for parents and caregivers. And there's also a website called Listening to Families, which is a series of short videos that has got Professor Warren Tate in it, and he talks about various aspects of MECFS and particularly with young people. So both of these resources are on our MECFS Canterbury website. So in summary, I think really important to find a doctor or a health professional who understands MECFS. The core symptom is post-exertional malaise, which is an increase in symptoms and reduction in function after minimal physical or mental activity. People living with MECFS can experience a wide range of symptoms. They're not just tired. It's not just about fatigue. There's currently no diagnostic test, but doctors can diagnose it using the criteria. The causes are complex, not fully understood. And so the approach to managing this disease is to manage the symptoms, which will stabilise MECFS and help improve quality of life. And people will often say, when they learn to pace, that they'll say, my life is smaller, but I feel better because I'm not doing that constant trying to push through and do something and then trying to deal with the crash afterwards. It's much more, a much better quality of life. And the two self-management strategies that are really important are pacing and rest. And unfortunately, the most difficult things to learn and to incorporate into your life. There we are. So thank you very much. Oh, I don't want that. Thank you very much for listening.
Thank you, Wendy. I see that some people have put some questions in the chat. Are you able to access them and see them?
Yeah. Let's have a wee look.
Start with that one.
If you're in the mild sector, would you stay there or do you move through? So does that, no, I think you may get worse and move through from mild to more severe MECFS, and often people who are at the severe end of the spectrum have started off quite mild, but when you go back through their history, very often what happens is that they've struggled to try and maintain their life, and they've pushed and they've crashed and they've pushed and they've crashed and they've pushed and they've crashed. So post-exertional malaise and dealing with that is often a large component, we think, of people becoming worse. But some people are mild and never go past that. They stay mild or they improve. Or some people, go to a moderate severe, and either stay there or improve. It's very, very variable. There's no there's no line of progression that every single person goes through. It's very individual. I don't know if that's answered your question. I hope it is. Yes, and the presentation slides will definitely be made available, and I think it's being recorded as well, isn't it? I'm recording it as well. Yeah. Was that all? No, I think there's another one. Oh, here we are. How do you find the right professional healthcare support? That's $1 million question. Well, there's MECFS Canterbury for a start, and there are two of us. We're nurses. There are two of us on staff, part-time. In terms of finding a really good GP, we sometimes have people recommend GPs to us, or another option, which people find really helpful, is just to go onto the Facebook page and ask around and say, who have people found helpful? Who would you recommend? You'll get bombarded with responses. Whether or not you're able to get in is another story. But yeah, that is also a really good way to get that healthcare support. And we can also refer for occupational therapy or physiotherapy, do those referrals as well for people that are needing equipment, or if someone's needing a little bit of work with exercise or breathing and stuff like that. If people want to join MECFS Canterbury, you can self-refer. Just go to our webpage, fill out a form, and put down, if you would like some nursing support, you can actually do that. I have to say there is, unfortunately, a few months waiting list at the moment. We are quite inundated, but anyone can self-refer to us. Yeah. Is there anyone else got any questions? Or I'm sorry that I have rushed through this presentation today. I just thought there's so much information. We usually do this in about an hour, so I had to really just sort of gloss over everything. But yeah, there's a lot to learn. Yeah.
Thank you, Wendy. That was so informative and wonderful that we have this recording to share with our parent community, and for our teachers that weren't able to make it tonight. It really has been so good. And I think one of the key things that I learned was the helpful tips that you've provided as you work with young people, and that holding on to hope, that this is your body telling you where you're at right now, but it's not forever.
Yeah.
I really like that.
Yeah, oh, that's good. Oh, thank you. All right, thank you so much for inviting me. It's been a real pleasure to talk to you, and yeah, I hope that that can be a bit helpful. So, yeah, thank you so much.
Kia ora. Mā te wā, everyone.
Bye bye.
Thanks.